This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Jeff Ratliff from Thomas Jefferson University and with the Neurology podcast. I'm here with Claire Henchcliffe from the University of California, Irvine. Claire's a senior author on a study published online in April 2025 in Nature that was titled Phase 1 Trial of Human Embryonic Stem Cell-Derived Dopaminergic Neurons for Parkinson's Disease. In this paper, Claire and her colleagues report the results of an open-label Phase 1 clinical trial examining the safety and tolerability of a stem cell-derived dopamine neuron progenitor cell transplantation into the putamen of patients with PD. While this is a phase 1 trial, we did want to talk with Claire about the study and what it may show us and teach us about a step towards stem cell-derived therapies for Parkinson's. Claire, welcome to the podcast.
Jeff, thanks so much for hosting me.
We're going to dive into the details of the paper, but I want to start off at a high level. And so what would you say are the key take-home points you and your colleagues hope this study will convey when it comes to developing stem cell-derived therapies for Parkinson's?
Okay, so, when our team started out, it just hadn't been done before. So the biggest concern was whether the transplants could be done safely without causing too many side effects. So I'm happy to say that in our study participants, that actually did prove to be the case. So at this point, we are more than 2 years later in everyone who received the transplant, and there's evidence supporting that the cells that were transplanted survived. And although I want to be very cautious, some of the participants seem to do better after the transplants. I'll also mention we were very lucky to publish back-to-back with another transplant study that was similar in some aspects from Professor Jun Takahashi's group. And I think having the two independent and slightly different studies really strengthens the findings.
Yeah, obviously having results be replicated and repeated in another cohort obviously is going to lend a ton of credibility to what we're going to talk about. And you touched on there's novelty to what you and your group did here, but this study is not the first time that surgical implantation of dopaminergic cells has been studied in Parkinson's. And so prior to kicking off this study that we're talking about, can you fill us in a little bit on prior experiences with these types of interventions and what was different or new in this trial in particular?
You're right. I kind of feel like we're standing on the shoulders of giants, and we definitely benefited from the various previous research groups' experiences. So this concept of replacing dopamine inputs into the putamen, the ones that are lost in Parkinson's disease, using transplanted cells, it's been really tested over several decades by now. In fact, when I trained, one of the major studies that was done, it was NIH-funded sham surgery, controlled transplants using fetal ventral mesencephalic tissue. And that had just been published by my mentor, Stan Farn, and a huge group of people. And I actually followed some of the transplant recipients in the clinic. So I just say that from that and from other studies, there's very tantalizing data from a subset of study participants who seem to benefit. But the larger studies just never met their primary endpoints. And the other problem had been some participants seemed to get quite severe dyskinesias related to the grafts. There are other research programs as well that had investigated tissue sources like adrenal medullary tissue, retinal cells, and others. But in those, I think the cells were very variable. They were hard to obtain in many cases, and the programs were halted. What we have learned is a lot about how to do this surgery, the types of people with Parkinson's, the characteristics that might make them well suited to an intervention like this, how to run the trials, length of trials. We learned a lot about using immunosuppressants in conjunction with the cell transplants. So I think these studies have turned out to be incredibly valuable, although obviously that's not how we're going ahead. Our trial was named Expedite. It was funded through Blue Rock Therapeutics, and it's new in terms of leveraging stem cell technology that's really advanced rapidly in the past 2 decades. And just one caveat, a few years ago, I was involved in an N of 1 trial of a gentleman who received autologous cells. This was a study that basically followed a similar rationale for cell replacement. But the ones that are getting published now and are being pursued now are larger trials with multiple participants. So we're learning a lot more. So these stem cells that are under investigation, I just want to make it clear there are kind of two types. We were working with cells that have been grown since the late 1990s. These are embryonic stem cells grown in the lab. But other groups are working with the induced pluripotent cells, or iPS cells. The advantage is that these cells can be grown in the lab in almost unlimited quantities. And thanks to the groundbreaking research that's taken place, they can be coaxed in the lab to become progenitors of dopamine neurons. They will survive, they will integrate into the host network, and that has been extremely well studied in preclinical models of Parkinson's. So basically, you can create huge banks of these cells that can be cryopreserved, banked. It creates easy access. It supports rigorous testing of safety and efficacy in preclinical models before you ever go near a human being. So I think that this stem cell technology has really overcome a lot of the barriers that the field has faced in the past with inadequate cells, jumbles of cells, or heterogeneous cell types, and inadequate quality of cells.
That point you make there is that a lot of the lessons learned in the past have dealt with the technical details and the refinement of the cells, where they're sourced from. And as you just said, how do we get them to become the type of dopamine progenitor cells that will be effective and that will survive once implanted? And as you were just describing, it sounds like these human embryonic stem cells from this culture that's been around for decades are, as you put it, coaxed in vitro through a series of steps into becoming dopamine progenitor cells that could become dopaminergic neurons. And those are surgically implanted into the putamen with a goal of providing dopamine or dopaminergic stimulation into the putamen, just as original dopamine neurons from the substantia nigra would. Do I have that correct?
Perfect explanation. Thank you. I'll just add that in the preclinical studies, Lorenz Studer's team, as well as Marlin Palmer's team and Jun Takahashi's team, have made massive advances. I know Lorenz's work best, so I'll speak about that. His team published in 2011 a new protocol for deriving these dopamine progenitor cells that would survive very nicely in preclinical animal models of Parkinson's disease. I'll just say that they not only survived, but they would connect to the host neurons, they would synapse, and in animal models of Parkinson's disease, these cell transplants would actually alleviate the motor deficits. And his lab performed some much more complex optogenetic experiments, and they actually demonstrated that as the cells could alleviate the motor deficits in these preclinical models of Parkinson's disease, they could demonstrate using optogenetics that the mechanism of action was delivery of dopamine from the cells. So you're absolutely right. The rationale is to provide dopamine at synapses between the transplanted and the host cells that would provide a smooth delivery. So very different from what those postsynaptic cells would be seeing if you're delivering dopamine, for example, using oral levodopa. Just as a side note, obviously, the native site for these cells would be the substantia nigra. That's where the cell bodies sit. And then during brain development, the axons are going to find their way up to the putamen. We are not asking them to do that. And so the cells are being transplanted directly at the site where the dopamine is needed. We're not asking them to sprout axons and undergo axonal pathfinding and all of that process.
I think that's a good and helpful clarification, is this is not just an implanted, for lack of a better term, clump of dopamine spewing cells, but the dopamine coming from these cells is coming through that animal model data. It's forming synapses, it's forming connections with the cellular architecture that's in there, and that it's a dopaminergic system that is more analogous to what is happening in a healthy brain.
That's what we hope.
And so now let's zoom out, and you touched on it as well, that patient selection, the type of Parkinsonian or type of Parkinson's disease patient that we study in these trials is also a result of the lessons learned from the past. And so looking at the cohort in this trial here, what can you tell us about them? How many patients were studied? what were some of the clinical features that led to patients being included or perhaps more importantly excluded from the study here of this particular intervention?
So we studied 12 people with Parkinson's, and as you said, they were very carefully screened according to rigorous inclusion and exclusion criteria, designed partly on what we knew from previous studies, but also by going back to basics and thinking about what can these cells actually do. And that really helped us, I think, to maximize potential benefit while minimizing risk and understanding that these participants are going to have to undergo not only brain surgery, but then a year of immunosuppression afterwards. So the people who were allowed into the study under the inclusion criteria were aged 60 to 78 in the US. They were actually, for the Canadian participants, they were 50 to 78. And these folks had been dealing with Parkinson's. They were allowed to come in between 3 and 20 years after diagnosis. Actually, the folks who participated on average had been dealing with Parkinson's for about 9 years. They had to have a levodopa response. And this was something we felt very strongly about, because if the people participating are not responding to levodopa, there's really a big question about whether they're going to respond to the cells. Now, it did not have to be a perfect response. And in fact, we didn't want people with a perfect response, because then why go through all the risk of a trial? And so we chose people who were not able to adequately control their motor symptoms despite considerable efforts and working with their neurologist. So we asked for at least 2.5 hours a day off time during which their symptoms were not controlled by medications. And actually, it turned out to be quite a lot more than that in our final participants. Unfortunately, we couldn't include people with significant cognitive decline and dementia or other severe non-motor symptoms that were really disabling them. And we know how important those are. But the feeling is that the cells, if we're relying on dopamine delivery, simply are not going to address those issues. And so it's a question of really not being able to provide a reliable benefit there. And again, they're going to get brain surgery, they're going to get immunosuppression, and so they had to meet a whole lot of other health criteria. So no major heart disease, no major uncontrolled medical conditions.
I think that's really helpful that these are patients that are typical of Parkinson's in many ways. They're a typical sort of age range of patients we see with Parkinson's with a typical duration of disease. And as you said, and as we see in the clinic, they respond to levodopa, but certainly they don't have an optimal response to levodopa. And as you said, they have off times, they have wearing off, they have fluctuations that obviously, if these results are propagated forward, we want to see, can we have an impact on those motor symptoms down the road? And I appreciate what you said about obviously you have to be good surgical candidates, and the cognitive decline we would not necessarily expect improve or change from dopaminergic stimulation into the putamen and into the striatum there. You alluded to it as well, and maybe just a moment to touch on a little more detail in the study around the time of surgery. And as you mentioned, following the surgery, there were measures taken to prevent rejection of transplanted cells. Can you describe that a little bit about some of the immunosuppression and some of those steps you took to protect those cells after they were implanted?
So this was a little bit controversial when we first started the discussions around immunosuppression, because some of the previous studies had used immunosuppression, others had not. There were still people who believed absolutely that the brain is immunoprivileged and that there is not going to be a rejection. And in fact, we do know from previous studies that a full-blown rejection that you might see, for example, with a solid organ like a kidney transplant, that's not going to happen in the brain. But what was really helpful for us is that Professor Takahashi's group, again, tackled this, and they published some really elegant experiments that showed in animals that if immunosuppression was used with unmatched cells, the cell survival and cell function was actually superior. And they actually test for matched cells as well. And so that was really helpful for us as we went through. The cells we used for transplant, they're from a single cell line. It was called H9 from Y cell. And these cells are not immunologically matched to the host. So we, after much discussion, felt it would be beneficial beneficial to proceed with immunotherapy that was pretty broad. And so we used tacrolimus and prednisone, steroid, for a year. But around the time of surgery, and this is probably when the cells are most vulnerable because you've got that breakdown of the blood-brain barrier, right? You're breaching that whole thing during the surgery. And so we also gave an immunosuppressant infusion at that time, and that was basiliximab. So this is really an area I'm hesitating because this is an area where we need to learn a lot more. Dr. Takehashi's group used a slightly different immunosuppression regimen than us. We don't frankly know what is the best regimen. We don't frankly know how long to continue that for. And when we talk about the outcomes and the side effects, a lot of the adverse events were related to immunosuppression. So it is a burden. We need better biomarkers to guide us. And then I'll just say, I still can't believe that people did so well because these participants with Parkinson's were immunosuppressed during the COVID-19 pandemic. And we had them flying around the country either to get scans or to come in for study visits.
Yeah, I don't think I had noticed that aspect of the timing, but that's obviously, I can understand how terrifying that may have been. A brief follow-up question. You mentioned the tacrolimus as part of the regimen, and we know that not uncommonly tacrolimus can even be associated with tremor and with movement disorders. And is that something that you all were concerned about, inducing a new drug-induced movement disorder in your Parkinson's patients who, again, maybe not in this trial as much, but if you go down the road, we're going to be looking at presumably UPDRS scores and motor scores down the road that could be influenced by the immunosuppression in and of itself.
Oh boy, that was a worry. Yes. I remember going through the exercise of laying out all of the different side effects of all of the different drugs that we were using. And we were also using some drugs for infection prophylaxis. So this was a huge concern. In our case, it led us in consultation with solid organ transplant experts, immunologists, neuroimmunologists. After some roundtables and a lot of discussion, we tried to keep the tacrolimus dose as low as possible. So we called it tacrolimus light. And we really monitored very carefully.
Good. And so we have this cohort of patients. They've undergone implantation of the intervention of these cells. And I understand that some patients got what you termed in the paper as a low dose and others got a high dose. And acknowledging, again, this is a phase 1 study focusing on the safety, the tolerability. What were the primary outcomes that you followed in these patients? What were the results on those outcomes?
What we called the lower dose was 0.7 million cells transplanted per side. And what we called the higher dose is actually 3 times higher, so 2.7 million per side. And there were 5 in the lower dose and 7 participants in the higher dose. In both of those cohorts, the primary endpoint was to collect data on safety and tolerability. And we decided on 1 year after transplant that we would report on that primary outcome. So we were monitoring frequently for adverse events, and we've continued to do that. And I just presented the 2-year data at a conference recently. In that first year, there were 2 serious adverse events. There were no deaths. That's the first thing. 2 serious adverse events. One of those was a seizure occurring after surgery. So that could have been related to the surgery itself. It never occurred, so we do not think that it was related to the presence of the cells. We were particularly monitoring for graft-induced dyskinesia. This was a second concern because those have been seen before, in particular in the fetal ventral mesencephalic grafts. And in some cases, they've been quite severe and had led to participants undergoing further surgeries. So in our study, we did not see that. We saw none of that at all. So the majority of adverse events, they were mild or moderate. And as I'd alluded to before, many were thought to be related to the immunosuppressive drugs. So headache, rash, fatigue, infections, and others. But importantly, again, we didn't find adverse events thought to be related to the cells. And no one dropped out. No one said, look, we just can't take this immunosuppression anymore. I dropped out.
The lack of dyskinesia, I think, is important to highlight, and I'm glad you started with that. But also, at least on the data you have in this paper, and as you continue to collect it going forward, that there does not yet appear to be adverse outcomes, again, related to the cells in and of themselves. And so we talked about those as primary outcomes. You and your team did look at some secondary outcomes, again, perhaps looking at maybe some early signals of clinical benefit, things like UPDRS or Parkinson's disease rating scores or fluorodopa PET scans. And so acknowledging these weren't the primary endpoints, but what did you and the team observe on some of those secondary outcomes in this cohort?
This was really a learning trial, and we had decided from the outset we are going to figure some things out here, and we wanted to very carefully describe the clinical courses and also, as you mentioned, the fluorodopa PET scans were being used as our biomarker to track, if you will, what was going on with the cells. So I want to be really cautious, but I think I can't help being excited. There's some great data here, and I'll just mention a couple of things. In our publication that took people to 18 months, we noticed several aspects in which motor performance seemed to be improved in at least some of the participants. And one example is the motor score off medication. So people had been off their medication overnight, and it was measured by the MDS UPDRS Part 3. In the low dose cohort, that improved by almost 9 points. But the big one for me was the high dose cohort, where it improved by 23 points, and that's from a baseline of 48. So again, it's a big shift. We don't know how much is placebo, and obviously it's an open label study, so there are all sorts of biases that can come in. The other big one for me, I think, was the Hauser diary, because that's been so widely studied and so well used and so well understood. And here we saw a number of changes, but again, the off time improved in the low dose cohort just by 0.8 hours, although that's not bad. But in the high dose cohort, it started from a baseline of 5 hours off time. And those 7 folks on average got down to 2.7 hours of off time. So I have to be cautious. There's no sham surgery, all sorts of biases. But then going along with the clinical data is the PET imaging. And we were using this 18 fluorodopa PET, and it demonstrated increased uptake at the surgical target site. And it was maintained after withdrawing immunosuppression. We have the results up to 18 months published in the paper. And I think this really strongly supports graft survival. And obviously, we're now following those participants in a longer term study that will take them up to 5 years post-transplant. So we're looking forward to seeing what happens.
Just to summarize what you said, and especially looking at some of that improvement in motor performance, right? Seeing clinically significant shifts in Parkinson's disease motor rating scales. And you alluded to the Hauser diary. And for those unfamiliar, it's a diary for patients with Parkinson's logging how much of the day they are in the on state versus in the off state, and another subjective measure of patients to self-report their symptoms. And as you mentioned, almost cutting in half some of that off time in that high dose cohort. These are unblinded and non-controlled open label subjects here.
But of course, small numbers as well. So it's entirely possible that certain individuals could drive the score.
Right. Yeah. From a statistical standpoint, small numbers. And so with this excitement, what's coming next? And you mentioned already there's going to be further observation and study of this cohort here and how those graphs do and how these patients do over time. But can you tell us about any other studies, phase 2, more controlled studies that are underway as we look ahead for this intervention in particular?
So this study was a phase 1 study. Normally you'd expect it to go into a phase 2, and then if that were successful, a phase 3. Actually, the cells are being taken straight into a phase 3 trial. We can't wait for that to kick off. There will be a sham surgery control. And so we'll get a lot more information, obviously, about not only safety and tolerability, but this time we'll be able to say something more about efficacy. This is a really fantastic time to be in the field, I'll just say. There are a number of groups across the world who have their own programs running. And obviously, we publish back to back with Professor Takahashi's team, and they're continuing with their IPS. It's iPS cell-derived dopaminergic progenitors. So we're looking forward to seeing more from them. But the initial results are very encouraging. Again, that was an uncontrolled trial. There's a group coming out of the fantastic research done in Sweden from Malin Palmer's group, and they're using a similar approach to us. So they are in clinical trials right now. And we should be recruiting for people to go through a natural history study and then enroll into the active part of the study. And then there are other groups, and I'm not going to name all of them, but I think there's a really interesting approach, which is to use iPS cells. When Dr. Takahashi's group took dopaminergic progenitors from iPS cells, they used one donor. But it is actually possible, and this is being done now, to take people's own cells, either skin or blood, turn those into iPS, coax them to be dopamine progenitors, and then transplant people with their autologous cells. So obviously that obviates the need for immunosuppression. There's some discussion around how beneficial that could be for everyone, and whether if you have a genetic predisposition to Parkinson's, would that preclude you from taking this sort of approach? So there's a lot to learn, but I think that's fascinating. So I'm telling all my patients to watch this space.
To summarize there, obviously lots of other groups looking at different ways of looking at these interventions. And as you mentioned, there's different ways to isolate the stem cells, looking at whether they're from the patient themselves or from these other sources of human embryonic derived stem cells, and then inducing them into dopamine progenitor cells. But you're totally right. We don't go a week of seeing patients with Parkinson's in the clinic and not encounter questions from patients, from families about what's going on with stem cell therapies. Are stem cell therapies available to me? And for years, I've tried to educate my patients about a lot of the complexities we've already talked about, differentiating cells, the safety of implanting cells. How do we get those cells to function in the brain as normal dopamine cells would? And so I'm interested to hear from you about how the conversations you're having with your patients are changing when your patients and their families bring up stem cell therapy in Parkinson's. What do you think it's appropriate for us to tell them today, and maybe about what we might be able to tell them in the future?
In my clinic, this kind of, for a lot of people, if they don't know much about it, this just falls in the general discussion that we always have about, are you interested in clinical trials? And if so, these are some of the things that you should look at. And in terms of advanced therapeutics, it's a really rich field because, we've got the cell therapies, we've got the antibody therapies, we've got the gene therapies, we've got all sorts of things going on. So that's a really rich conversation. For the cells, I try to educate them a little bit because I think a lot of people think that for stem cell therapy, it's something where, you take your belly fat or you take your blood and you just inject it intravenous and you go on your way and $10,000 lighter. And so I think a lot of my patients are surprised when I tell them actually what goes into it, that it's general anesthesia, it's a brain surgery, it's immunosuppression, it's frequent visits. So I think the education is a big part of that. And definitely that's where some people say, well, it's not for me. But I think, oh gosh, there is hope and there is optimism. And that's why I love telling people about this. As we said, there are other groups working on it. Some are taking an approach that while it's more technically difficult, it might have advantages for some patients. So I try to educate people about where they can keep track of what's going on in the field, whether it's signing up for patient advocacy group newsletter, or for some people, they go online to www.clinicaltrials.gov and they will screen through it just like me and my colleagues do. So that's a lot of what I love talking about. The part that I don't love so much is I know there are a lot of people who come in who either are considering or in some cases have had so-called therapies that are on offer for payment. So these kind of, I guess, rogue clinics is what some people call them. It's hard because some of these interventions, I shouldn't say therapies, are presented in a really sophisticated way, with some science around it. And so it's very plausible. And I think it's really hard for patients to judge how valid that is. And certainly it's tough because there's no published data. These clinics are not going out and publishing, oh, here's my outcomes on my last 100 patients. And so I think there are some red flags. Oh, before I get into the red flags, I should say this is really serious. It's not just that people are losing money to pay for this, but there have been cases of severe complications. And so I think the red flags are being asked to pay for an unproven therapy. There are other red flags, which is going to a clinic which is offering stem cell therapies that cure, or more importantly, help multiple different disorders. So how are we going to have one thing that helps, multiple sclerosis and Alzheimer's and Parkinson's and so on and so forth? So those are really the difficult conversations to have, I find, but it has to be.
I'm really glad you mentioned that. And as a symptom of the really overwhelming desire to cure or really have drastic improvement in their disease, as you just said, patients will go to extreme means and might be susceptible, or often are susceptible to, as you put it, these rogue clinics that are probably in many ways taking advantage of that desperation or that desperate feeling that patients have. And this isn't a straightforward intervention. As you said, it requires general anesthesia. It requires the involvement of a neurosurgical intervention. Depending on the methods that might get ironed out, it might involve immunosuppression, right? So it is not straightforward, as you said, get a blood draw and then reimplant it somewhere else and go about your day. And so we have to be able to give our patients hope and talk about the science that is moving this area of therapeutics forward. But as you just said, we also have to educate them on safeguarding themselves and not latching on to something that is too good to be true and teaching them how to identify that. I think that's valuable.
Well said. Well said.
Claire, thank you. I've been speaking with Claire Henchcliffe from University of California, Irvine about her paper published in Nature titled Phase 1 Trial of Human Embryonic Stem Cell-Derived Dopaminergic Neurons for Parkinson's Disease. Go read the paper, and as Claire said, keep an eye on this space to hear more about future studies coming down the road. Claire, thank you again.
Thanks for hosting me, Jeff. Really enjoyed talking with you.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.